Oh.
Hello?
Hello.
I'm Nikos.
Hey, how you doing, Nicholas?
You are a big phenomenon of the neurosurgery. I'm really admiring you.
Well, this is fun. Are you kidding? We did this for a long time. Not many people were interested, but now there's more interest. You probably noticed that, right?
How many years did you have this neurosurgical degree?
Well, a couple of years. We did it with Google Hangout first, which is like a video platform. Have you ever heard of Google Hangouts?
Yes, yes.
Yeah, we tried them for a while, but it didn't catch on really. I think Zoom got a little simpler, and they took better care of the platform because Google's not really interested. They're interested in other things, and they were kind of letting it go. Okay, I'll be back in a few minutes. I got to do
Okay.
some.
Nice to see you. Nice to hear you. Okay.
Thank you, thank you.
Okay.
My video. See here. Where's Dr. Sabea? Dr. Sabea, how you doing, Dr. Sabea?
Hi, I'm fine, thank you.
You changed settings.
Yeah, I am in my clinic now.
Oh, okay. I don't know if you want to try to get a background. That background's fine.
They are allowing us to go back to the clinics and operate on selective cases.
Oh, okay, okay, okay. So you're not only seeing patients doing minor procedures?
That's right.
Okay. Well, that's good. We got about 8 minutes, okay?
Sure, sure.
Okay, let me just do some last minute stuff.
Yeah, of course, yeah. انت بدك تقعد هون ولا كيف؟
Hi, Dr. Sabea.
Hello.
Yeah, could you get off the screen share so I can introduce you and people can see your face?
Yeah, of course.
Yeah, and then you can go onto the screen share, because otherwise they just see a little picture of you in the corner.
Sure.
You know what I mean?
Yep.
Okay, very good. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. It's Dr. John Bennett, broadcasting for Neurosurgical TV. We have another episode of Jordan Neurosurgery Grand Rounds with Ibrahim Sabea, a well-known Jordanian neurosurgeon as well as educator. He's been doing these for 27 years, and now he's taken to the internet to reach his followers and to spread his teachings. Okay, I'll just turn it right over to Dr. Sabea, and thank you for doing this, and it's all yours.
Thank you very much indeed. Okay, I would say good morning, good afternoon, good evening, wherever you are. I'm Ibrahim Sabea. I'm transmitting from Amman, Jordan here. Fortunately, the confinement is being lifted and we are allowed to go back to our clinics. But there is a certain limitation on the movements. So, the topic for today would be giant vestibular schwannoma. So we're not taking schwannomas or vestibular schwannomas in general. We are concentrating on the giant ones. And as usual, we will take it from the clinical, radiological, operative, and pathological correlation. Before I start, this is some of the slides from Jordan. We are in springtime, and this is springtime in Jordan. These are some of the pictures. We're not enjoying summer because we're not allowed to go out, but at least these are some pictures for you. It's a beautiful scenery here in Jordan. And this is the black iris, which is the symbol of Jordan. So before I go into the vestibular schwannomas, the large ones, let me just take a few points and 3 slides on the temporal bone. Temporal bone is made of squamous part, vitreous part, tympanic part, mastoid, stylomastoid process, the zygomatic part, and we can add the 3 ossicles. So it's made of 9 bones, as it were. This is the left temporal bone. This is the squamous part. This is the zygomatic part, mastoid part. We are not seeing the vitreous part, which is on the other side of this. And we have the tympanic part here. And of course, as I said, the 3 ossicles inside. This is looking at the left temporal bone from inside. So this is anterior, this is posterior. And you can see the sigmoid sinus comes here. This is the internal digital meatus, and this is the clitoris apex. This is, of course, the arcuate eminence, which is the landmark for the superior semicircular canal. Again, here, looking at the left temporal bone from inside, this is the sigmoid sinus. And here we can see the three ossicles, here the three semicircular canals. Same thing, left side. This is the internal digital meatus, jugular foramen, and here is the Trautmann triangle through which we do the pre-sigmoid approach. Same thing, the left temporal, concentrating on the left temporal. I will show you left and right temporal so that we'll get orientated with both sides, left and right. So this is a superior view of the left temporal bone, a cadaveric specimen. You can see the internal digital meatus with the nerves going in. In the front here is the facial, underneath it is the cochlear, behind it is the superior and inferior vestibular. And you can see the ICA loop going in there. This is the external ear, the tympanic membrane here, tympanic cavity is here, and you can see the semicircular canals and the mastoid antrum. Still on the left side, this is here anterior, this is posterior. You can see the trigeminal nerve on the trigeminal impression, and then you can see the upper surface of the left temporal bone. Here you can see this quadrangular bone, which is called Kawase, quadrangular Kawase triangle. And then after that, we have a place for the internal meatus. And then we will have the superior semicircular canal. And here, of course, is the tegmen tympani. So still on the left side, trigeminal, Kawase triangle, the tympanic, the internal meatus, but of course covered here, the superior semicircular canal, and here we have the external canal. Same thing here. Let's show you further anatomy. This is the greater superficial petrosal nerve, and this is the superior semicircular canal. If you drill here, you will see the internal meatus. And here is the Kawase triangle. So the same thing, we are on the left side. You can see the internal meatus, and you can see that these are the semicircular canals. This is the greater superficial petrosal nerve, and this is the Kawase triangle. And here tucked, and here is the cochlea. Same thing in here. Again, looking at the left temporal bone, this is anterior, this is posterior. You can see the geniculate ganglion and the greater superficial petrosal nerve, which is a branch of the facial. Here is the labyrinthine part of the the labyrinthine part of the nerve, the facial nerve. Same thing here. If you drill the Kawase triangle here, behind you will be internal canal. Behind it will be the superior semicircular canal. So here now changing to the right side, so that will get orientated with the right and the left. Again, this is looking at it from above, superior view. This is the internal meatus with the nerves going in. And then this is the eustachian tube, lateral to the carotid. On top of the carotid is the greater superficial petrosal nerve. So the geniculate ganglion is here. This is the superior, posterior, and lateral semicircular canal. Add to this, so-called, usually late Professor Roten would tell you that there is a Y arrangement. This is the external auditory canal, and then this is the limb of the Y. This is the eustachian tube, and the other limb of the Y is the internal meatus. So this way you have a Y-shaped arrangement, and here are the semicircular canals, superior, lateral, superior, posterior, and lateral. This is the here the mastoid. Same picture. On on the left side. To remember the Y-shaped arrangement, external hiatus, this tympanic cavity, these are the ossicles, the eustachian tube, the carotid, the lateral superficial petrosal, internal of the canal. So Y-shaped arrangement, right and left. So let's look now at the vestibular and cochlear nerve anatomy. The nuclei of the vestibular nerve lie here in the floor of the fourth ventricle. As you know, this is the stria medullaris. We have upper triangle and lower triangle. And these vestibular nuclei are distributed in the upper and lower triangle, superior, inferior, medial, and lateral vestibular nuclei, while the cochlear nuclei are medial and lateral, and they're more towards the lateral recess. These are the three nerves, the facial in the middle with the nervus intermedius between the vestibular nerves, superior and inferior, and here is the cochlear nerve. So cochlear, vestibular, upper and lower, and in between them we have the facial and the nervus intermedius. Another view here is the external canal, the tympanic membrane, the three ossicles, malleus, incus, and stapes. Oval window, these are the semicircular canals, and this is the cochlea here. So the superior and inferior vestibular nerve go to the vestibular apparatus, the cochlear nerve goes to the cochlea here, and here is the eustachian tube. And these are the three ossicles which we have seen, the malleus, the incus, and the stapes. Put them back here, as in here, the malleus, the incus, and the stapes. The three nerves, they come through the sulcus between the pons and the medulla. Here is the facial nerve and intermediate nerve, and here is the bundle of the vestibulocochlear. What about facial nerve anatomy? We described this when we discussed the abducent nerve. We said that the blue here is the nucleus of the fascia. Instead of it coming this way, it goes around the nucleus of the sixth nerve and then comes out. This is kind of embryological development, but this is the facial nucleus. And when it comes, it has two roots, the motor root, which is the large root, and the smaller root, the nervus intermedius, carrying the parasympathetic fibers. Eventually, it's going to give the lacrimal, submandibular, and sublingual glands. Now, the two are separate on emergence, but when they reach the internal auditory canal, they merge together. You cannot differentiate them. So basically, we speak about segments of the facial nerve. As it comes from the brainstem, there's a segment here called cisternal, and then it goes into the meatus. This is called meatal. And then this is the labyrinthine part, because it is related to the labyrinth. And then this is the first genome, the geniculate ganglion. And here is the tympanic part of the facial, and then the second genome and the mastoid part of the facial. So this is general overview. This is from book of Sana, and you can see here that you have the facial nerve coming this way. This is the mastoid part, and then this is the peripheral part. So let's take them one segment by the next. This is a view that you see in the right retrosigmoid, attracting cerebellum medially. You can see the intended meatus. You can see the facial nerve. You can see the vestibulocochlear bundle, and you can see the eye looping into there. Here are the lower cranial nerves. The meatal, through the same view. Here, of course, was the bone. If you drill the bone, you will see the dura lining the canal. If you open the dura lining the canal, you can see the facial going anterior. Underneath it is the cochlear, and behind it are the superior and inferior vestibular nerves. This is a good view of the nervus intermedius of the facial. So facial underneath cochlear anteriorly. Posteriorly, you have the superior and inferior vestibular nerves. Like in here, facial nervous intermedius and the superior and inferior vestibular nerve. As you can see, they are going through the hiatus, and we'll have a look at the hiatus that it has 4 compartments for each of the nerves that we have mentioned. So here you are. Anterior, here is posterior. We are looking at the fundus, facial nerve, cochlear nerve anterior, superior and inferior vestibular nerve posterior. So this is Bill's bar, and this is the transverse crest. Another look at the hiatus. You have the facial here, and you have the, underneath it is the cochlear, going to the cochlea. You have the superior and inferior vestibular nerve going into the semicircular canals. And these are the crosses of the semicircular canals. See how close the facial nerve is to the cochlea when you reach to the fundus. Now this is important because once you drill the canal, the internal auditory canal, you have to be aware of this anatomy. Otherwise, you may damage the cochlea. So this is now a superior view of the right temporal bone. This is anterior, and this is posterior. And here you are drilling the bone, internal auditory canal, coming to the dura lining the internal auditory canal. Open the dura and you'll find the facial nerve anterior and both the superior and inferior vestibular nerve posterior. Underneath the facial is the cochlear nerve. So facial and cochlear anterior, superior and inferior vestibular nerves going into the vestibule, going into the semicircular canal, and this is the vestibule. Further dissection, you can see facial related to the cochlea anterior. You can see the cochlear nerve going to the cochlea, and you can see the superior and inferior vestibular nerve going into the semicircular canals. This is the oval window. Looking at the right temporal bone from inside, this is petrous apex here, this is the internal auditory canal, facial, nervus intermedius. Underneath here, you can see it is the, we see it actually, this is the cochlear, and these two are the vestibular nerves. You can see the relation to the superior petrosal sinus, to the trigeminal nerve, to the carotid, petrous carotid, where the bone was drilled to show you that, and the jugular foramen. So here is the superior semicircular canal, posterior semicircular canal, and this is the vestibule. And from here, you can see the endolymphatic ducts into the Trautmann triangle here. This is the endolymphatic sac. Let's come to the labyrinthine segment. Once the nerve comes through the internal meatus, then follows the labyrinthine part, labyrinthine segment, right from the meatus till the geniculate ganglia. So this is the labyrinthine part, and from the geniculate comes the greater superficial petrosal nerve, and this is the tympanic part. So finish the meatal part. This is the labyrinthine part, the geniculate ganglion, and the tympanic part. The nerves coming in here, and you can see that we have the cochlea, and we have, so these are the nerves. This is the cochlea. This is the labyrinthine part, greater superficial petrosal part, the tympanic part. These are the semicircular canals. And the tympanic part, you will find that the tympanic segment of the facial nerve is related to the lateral semicircular canal. Tympanic segment, the same thing. We have the nerves coming in, anterior superficial petrosal, and this is the tympanic in relation to the lateral semicircular canal and the tympanic cavity. This is the eustachian tube. Nerves coming in from the meatus, the labyrinthine segment, geniculate ganglion, greater superficial petrosal nerve, and the tympanic part in relation to the lateral semicircular canal. These are the semicircular canals, superior, lateral, and posterior. Superior, lateral, and posterior, and the tympanic part is related to the lateral semicircular canal. Mastoid segment, looking at the right mastoid segment, you can see that this is the line where the facial nerve comes. This is spine of Henle that points to the antrum. And if you dig deep inside, you can see the mastoid segment of the facial nerve, and this is the chorda tympani. Chorda tympani eventually will leave the nerve and join the lingual nerve to go to the submandibular and sublingual gland. Here, this is a view showing you the external canal, the tympanic membrane, the ossicles, and the nerve and its mastoid part. Same arrangement. And then it comes from the stylomastoid foramen, and then it divides into the 5 major branches: the frontal, temporal, zygomatic, and the buccal, and the cervical parts to the ansa cervicalis, and to the stylohyoid muscle, and to the posterior belly of digastric. These are the facial muscles of expression. This is the right side. The nerve is coming out like this through the parotid gland, dividing into various branches that we mentioned. If we look on the left side, just the same arrangement coming from the stylomastoid foramen and then going into the branches. The one branch that we always talk about is this temporal branch, temporal and frontal branches of the facial that can be damaged if you are not careful how to open the temporalis faciae. Same thing, the same arrangement. On the left side for the facial, this is the facial and this is the greater superficial petrosal nerve going into the pterygopalatine fossa and otic fossa. And here is the nerve as it comes through the parotid. And here, through the mastoid segment, it sends the chorda tympani, which joins the lingual nerve to give the submandibular and sublingual glands. Let's look at the radiology of all this. This is a picture of the medulla and coming towards the pons, and you can see the nerves going into the internal meatus. You can see ICA here. Concentrating on the right side, the basilar, the ICA here, and these are the nerves going into the internal meatus. Always the one which is anterior is the facial, and underneath it is the cochlear. Behind it are the superior and inferior vestibular nerves. Same arrangement, facial underneath the cochlear. Behind it, the superior and vestibular nerves, the cochlea, and the semicircular canals. You can see the turns of the cochlea. You can see the semicircular canals. Same thing here. You can see the arrangement, the cochlea, and the 3 canals as one can see. Again, in the axial cuts, you can see the labyrinthine part of the facial nerve. As we said, it comes this way and then goes anterior towards the genu. This is the greater superficial petrosal nerve, and this is the tympanic part. So this is the tympanic part, and the axial cuts go this way in relation to the lateral semicircular canal. This is again the tympanic part. It's a long segment. Here is the second genu of the nerve, where it turns from the tympanic segment to the mastoid segment. And this is the mastoid segment, the beginning of the mastoid segment, and so on. Okay, coronal cuts, you can see the cochlea here, the facial nerve here, and you can see here the thin part of the nerve, the geniculate ganglion, the tympanic part, and this long is the mastoid segment. Here is the stylomastoid foramen. So it's an interesting pathology, osteology there that one has to remember. But once you get a lesion in the cerebellum-pontine angle, what is the differential diagnosis? It is really wide. Of course, we speak about schwannomas, and the commonest, of course, is the vestibular schwannoma. But other schwannomas could be just inside the cerebellum-pontine angle. Trochlear, trigeminal, abducent, facial nerve schwannoma, schwannoma of the jugular foramen, vagus nerve schwannoma, accessory schwannoma, hypoglossal schwannoma, and all these are in my series from my cases. Petroclival meningioma is the second commonest lesion in that area. Of course, it's more, we have to speak more of the cerebellopontine angle meningioma rather than petroclival. It is the second commonest differential diagnosis in the cerebellopontine region. Arachnoid cyst comes third, and then the rest of the pathology: chondrosarcoma, endolymphatic sac, hemangioblastoma, glioma going into the angle like this, epidermoid, and chordoma and chondroma, giant cell tumor, lymphoma, ependymoma to the angle, metastasis, hygromas jugulare, and then comes the cholestral granuloma and the variants of the lesions that affect the petrous apex, simple effusion or fatty marrow or mucocele, apical petrositis, encaphalocele, and so on. Giant cell tumor, choroid plexus papilloma going into the lateral recess like this. The rare variant of the lateral medulloblastomas, the aneurysms, the neurosarcoidosis. Again, you cannot learn this except if one reads from textbooks. This is my advice to the young neurosurgeons, to the neurosurgical residents: please do not read from handbooks. From now, put your mind into reading from textbook. I'm not trying to commercialize any textbook whatsoever. I love to read from Yazerjil. I love to read from Yazerjil. Before he actually produced his books, I used to read his articles. But since then, I'm reading from Yazerjil. I have not finished it because I used to go back to it every now and then as a resident and as a neurosurgeon. I also took Roten for the anatomy, took Osborne radiology, took the pathology, Russell and Rubinstein, took the neurology by John Batten. So please read from textbooks. All this information that I gave you are in textbooks. You will not find it anywhere else except in these textbooks. And to update yourself, you have to read from journals. And these are the 7 journals I read every month, and I am on the editorial or advisory board of these journals. Please do not read from handbooks. The Greenberg is not a textbook. It is a handbook. I have to repeat this and hammer it till the day I die. So back to the giant vestibular schwannomas. Let's see what's happening. Schwannomas in general constitute 8% of the tumors. Meningiomas about 20%, pituitary about 18%, and so on and so forth. Schwannomas 8%, and the commonest schwannoma of them all is the vestibular schwannoma. The rest of the schwannomas, abducent, trigeminal, they come next. And the very good classification of these vestibular schwannomas is done by Majid Sami from Hanover. And whenever you mention vestibular schwannomas, you have to stop and mention something about Majid Sami. This is Majid Sami. He's my mentor, he's my friend, he's a father figure for me. And back in 1999, he appointed me as a member of the WFNS Skull-Base Committee. This is a great honor and pleasure by Professor Majid Sami, who is really a father figure for me. Also, I joined the WFNS administrative board, and here I am with Professor Sami. Professor Sami is a family. He is a friend of my family. This is my wife. And he's also a friend of every member of my family. And my daughter, Asil SBEIH, who is the 5th year neurosurgical resident, spent about 3 months time with Professor Sami. And he was happy with their progress. Professor Sami is not a friend of mine and my family. Is a friend of Jordan. I think every neurosurgeon in Jordan has a connection with him. He's a great man, he's a great mentor. He helps a lot, and I hope him good health and good life. He is in one of the conferences with Professor Rizajil and Iman, and here I'm visiting the institute, the NE Institute in Hanover, and here we are together in Bulgaria. So Professor Sami classified these schwannomas into T1, which is inside the canal. T2, it's just coming out of the canal. 3 is divided into 3A and 3B. 3A filling the system but not reaching to the brainstem. B is actually reaching the brainstem. 4A is compressing the brainstem. 4B is a very harsh compression of the brainstem and dislocation of the 4th ventricle. And to this, you add T5. And T5 is the one which is crossing the midline. So, pure intracanalical like this, it is inside the canal. This inside the canal and just reaching to the edge of the internal determinatus. 3A is filling the system but not touching the brainstem. B, it is touching the brainstem. 4A is really compressing brainstem. 4B is really compressing, with severe compression with distortion of the ventricular system. And the grade 5 is the giant crossing to the midline. We've mentioned that. In my series, I've seen cystic acoustic neuromas, which is mentioned by Professor Sami in his series, but this is one Iraqi patient who we could not perform MRI on him because he had a bullet through the Iraqi war that happened. And this is the cystic schwannomas as it appeared on the CT scan because we could not do MRI. And this is how it looks intraoperative. I also have this very interesting case, which I call triple pathology. This is the vestibular schwannoma. This is a trigeminal schwannoma, and this is the arachnoid cyst in the same patient. I have lots of cases of NF2 where you have bilateral schwannomas in addition to other tumors. And here again, the NF2 series that I have. I think we will discuss it on some other occasion. Now, I want to point out this important relationship. The question is, where is the facial nerve in relation to the vestibular schwannoma? Now, as we know, this is the facial, this is the cochlear here, and here is the superior and inferior vestibular nerves. This is the origin of the schwannoma, superior or inferior vestibular. So where is the facial nerve in relation to the tumor when it happens? So this is superior vestibular schwannoma, and look where the facial nerve is. So if the superior vestibular nerve is the origin of the tumor, it will take the facial nerve this way. If the inferior vestibular nerve is the origin of the schwannoma, facial nerve would go this way. So compare this to this. Actually, people say most of the time facial nerve is anterior or anterosuperior to the schwannomas. Correct, but it could be anywhere. And Vijay used this paper to see where is the facial nerve, 2011, and you can see using the diffusion tensor, this is where the facial nerve is. So usually anterior superior or anterior, but it could be posterior. Another paper again from China about the use of imaging, tensor imaging to see where is the facial nerve in relation to the tumor, which is an important radiological finding. So back to the giant vestibular schwannomas. Are these common? Are these giant ones common? They are rather not common, but we see them. And this paper back in '95, atypical invasion of temporal bone and vestibular schwannoma, they destroy. They don't only dilate the internal meatus, they destroy the petrous bone. Look at here, the destruction, and here. This is another vestibular schwannoma invading temporal bone, destroying it completely. Another schwannoma extending from the internal canal into the jugular fossa. Very unusual. What's the management of these vestibular schwannomas? Wait and see policy is acceptable in small intracanalicular schwannomas with no manifestations or minimal manifestation. You have the right to wait and see after discussing it with your patient. The major management of these large vestibular schwannomas is microneurosurgery. This paper, 2010 by Professor Sami, I think his collection is now something like 5,000 cases of vestibular schwannomas. And this particular one about the giant ones, and he's looking at the 50 patients with giant ones, and he's looking at the hearing function, 25 poor, 25 fair, 50% good hearing function, and these large schwannomas. Another paper back again, recent one, 2017, with these large schwannomas that can be actually excised. So what the conclusion is that all cases of vestibular schwannomas, irrespective of their size, complete surgical removal and preservation of facial nerve function should be the goal, and in case functional hearing is present also. So retrosigmoid, intradural, suprameatal, inframeatal approach for removal of giant schwannomas with severe petrous bone involvement is possible and practical with low morbidity. This is the only way to treat these giant ones. It is not for novices, it is not for radiosurgery, as I would allude to later on. Another paper from France, surgical management of large schwannomas needs surgery. You cannot use radiation here. Not all the tricks of radiosurgeons must be used here, none of them. They came up with the trick of making the tumor smaller and then give it radiation. Excuse me. Debulking the tumor from inside and then give radiation, or fractionation of the treatment. All this to me, they don't apply. I don't subscribe to this unusual way of treatment. Management of large and giant vestibular schwannoma by surgery from London, from Michael Gleason. And here is the results from complete surgical removal, the series of the authors around the cases of radical excision of these tumors. Of course, there are complications, wound infection, meningitis, CSF, etc. But this is the only way that anybody who is practicing good neurosurgery, who has good sense, must use. From Mayo Clinic, 2018, there comes this paper. This is about the Skull-Based Society of North America, Canada, and United States. And the major contributor here is Jack Marcos, my friend from Lebanon, who resides in Florida. And they looked at the various centers in the North American, Canada, and United States. Total of 57 centers or surveys were returned. Most respondents claimed to have over 20 years of experience, and the majority reported working in academic practice. What is the result? 86% they operate on vestibular schwannomas. 86%. I'll show you some bad surgeries done in this part of the world, and I'm sure it can happen in any part of the world. Look at this schwannoma. Obviously, there is a novice, a very unexperienced surgeon, who decided to cut the cerebellum completely, transect it to reach to this tumor. And did he remove it? No. You just damage the cerebellum, cause the patient facial nerve, hearing loss, and the tumor is the same. This is crime against humanity. These people should be stopped. We should have the courage to point out to these, point your finger towards them and say, stop it, because this is a crime against humanity. Another crime is schwannomas with the hydrocephalus. Just put a shunt and send for radiotherapy. Another crime against humanity. That's why I published this paper in the Surgical Neurology 2009, and I called it, Do We Need a Neurosurgical Interpol? And I do mean it. We do need neurosurgical Interpol to stop those murderous neurosurgeons who are practicing bad neurosurgery and reflecting badly on our very good profession. There are a lot and lots of good neurosurgeons, but there are bad neurosurgeons among us. Let's come down to the gamma radiosurgery for these giant ones. Let me take the thing from the very beginning. Let me take you back to the beginnings when Lars Laxell, who invented the gamma knife in Stockholm, in Sweden, used this, and he called it STEREOTACTIC radiosurgery, gamma knife radiosurgery. And by definition, this is the delivery of a single high dose of radiation to a small and critically located intracranial volume. Indications are very limited. Elderly patient who cannot tolerate surgery, major concomitant morbidities, or recurrent disease. You have done surgery and it came back. And they have added this, and this has been added recently to allow those people who cannot do surgery to practice radiosurgery unethically. When patient refuses surgery, and of course, if you go to the patient and say, would you choose radiosurgery or surgery? Surgery means that I have to open your head and there is risk of dying and this and that. Or do you choose radiation where I give you radiation now and 3 hours you go home and you cook your meal? Of course he would choose, he would refuse surgery. So it is the essence of what do you tell the patient. History of radiosurgery or gamma knife, Stockholm 78. Next was Buenos Aires, Sheffield, United Kingdom, Pittsburgh, United States, Charles, Virginia, 87, and Jordan here is 96. And this is me in training in gamma knife. This is Ben Carlson, our mentor, and you attend your certificates. And this is the first gamma knife in the Middle East. This is me, 25 years younger, treating the very first patient with vestibular schwannoma. Gamma radiosurgery usually is performed nowadays for tumors which are less than 3 centimeters. But do radiosurgeons stop at this? No. They would take the size up to 6 centimeters and they would treat it with fractionated radiosurgery. They will not stop. They always bring something out of their sleeve. And instead of not treating this with radiation, they would say fractionated radiosurgery. What a terminology is this? Even in the those cases or those series where they treated large vestibular schwannoma with the gamma, they would encounter the conclusion. Surgical resection is the fair choice. And the same papers produced by the radiosurgeons. Show you some. Bruce Bullock from Mayo Clinic, producing this paper 2010 about the control or the results of the gamma knife treatment. Number of tumors getting smaller, only 16 out of 47. Number of tumors smaller, 18 out of 82. So it's not a very good result, actually. This paper from Jason Sheehan from Charlottesville, Virginia. This is large. I mean, how would you give radiation to this brain stem compression, knowing fully that the result of the gamma radiosurgery only appears, it starts to appear 6 months after you give radiation? How would you leave your patient with this pressure on the brainstem for 6 months, up to 2 years. And what is the result? Is this. They say control of the tumor with severe compression of the brainstem. I don't buy that. I don't subscribe to that. In the same paper, look at the results. Unchanged, 6. Decrease, 10 out of 55. Increase in 2. Requiring treatment surgery is 6. And when they require surgery after gamma knife, it's hellish of surgery, as I will show you. So gamma failures, 4 out of 18. Is there death from gamma knife? Yes, they reported 1 case. So there is major complications from gamma knife. In you see cranial nerve deficits and so on. From the Mecca of radiosurgery in states from Pittsburgh, Pennsylvania, Douglas Condiolka, who's my friend, gamma radiosurgery for large volume vestibular schwannomas. And you can see this is the tumor, this is the tumor, this is the tumor. Well, maybe good result, but you have left your patient with severe compression for a long period of time. And is this the final chapter? No, I don't know whether it comes back again or whether it will turn to be malignant. So 7 patients needed in his series resection. This is the criteria of these cases. 7 needed resection, and resection after gamma knife is really hellish. This paper from China, JNS 2018, look at this. How one would give radiation to this tumor? I have no idea. I would wish somebody would actually tell me who in his own mind would give this volume of a tumor causing this severe compression of brainstem any kind of radiation, being conventional radiotherapy or being fractionated radiosurgery or whatever. And look at the follow-up, 6 months, the same, 1.5 years, 2 years, 3 years, 5 years, and 7 years. For goodness me, for goodness sake. Another idea, a new idea, they always produce something out of their sleeve. Jason Sheehan, and they said, well, this is the tumor, let's take it from inside and then give gamma knife. You subjected your patient to surgery unnecessarily, you subjected him to gamma knife unnecessarily, and the result is that the tumor is there with some complications. Same thing, let's do subtotal resection and then give the gamma knife. You've been there. Why not to take this tumor out? Why did you stop there? Are you afraid of complications? Complications would happen with this kind of surgery, whether you leave this part or not. So you subjected your patients to risks of surgery in that very critical area for no good reason. Combined surgical resection and gamma knife radiosurgery. Again, for goodness sake, how would you give radiation to this kind of compression on the brainstem? Take some part and give radiation to the rest. So there are paradoxical trends in the management of vestibular schwannomas in the USA. And look at this paper by Lansford from Pittsburgh, worldwide variance in the potential utilization of gamma knife radiosurgery. This is an acknowledgement of the variance of management of these cases. Look at this beautiful paper. Does where you live influence how your vestibular schwannoma is managed? Of course it is. It depends on where you live and is this a gamma knife or no gamma knife, the person is experienced with surgery or not. So there are limitations of radiosurgery, mainly the size, the close association with the optic apparatus. There are late recurrences and they'll come back, and then will you do surgery, and surgery is difficult. And then the malignancy, which is a bit of forgotten complication of radiosurgery. Look at this. It is impossible to make an accurate assessment of the magnitude of radiosurgery-induced tumors. Well, radiosurgeons, they don't like this. They don't like this terminology. When you say radiosurgery-induced tumor, they say, no, this is radiosurgery associated with gamma knife. No, it is radiosurgery-induced tumor. And why we are not seeing lots of cases? Because there was short follow-up. Still, we don't have gamma knife cases with a long follow-up, 10 years or more, 13, 15, 20 years. We have not seen them. Look at this paper from Canada, 2007, a glioblastoma multiforme after stereotactic radiotherapy for acoustic neuroma. Look at this, JBM. Radiation-induced sarcoma in large vestibular schwannoma following radiosurgery. So this is the case increased after gamma knife surgery, and it was changed to malignant 7 months after gamma knife. This is from Mayo Clinic, Rochester, Minnesota. Radiation-induced osteosarcoma after gamma knife surgery from South Korea. This is the lesion given gamma knife, 4 years later, increase in size, removed. It was osteosarcoma. Temporal lobe gliosarcoma after gamma radiosurgery for vestibular schwannoma. You can see that this is from Mayo Clinic, the tumor, and this is the malignant. Malignant transformation of vestibular schwannoma, 6 years after gamma knife. 6 years, because we have waited this long. We discovered that it recurred, and when we went for surgery, it was malignant. Malignant transformation, 10 years after gamma knife. A paper from, I think from England. You can see the tumor increase in size, removed 10 years after gamma knife. So this is the reason, because we don't have this long follow-up of these cases. We are not speaking about recurrences and malignancies as complication of radiosurgery, simply because the people who treated it with gamma knife, they are either mediocre surgeons who cannot do the surgery. They've used the gamma knife simply because it suits their purpose, not because it is the right thing for the patient. 7 months after gamma knife, this is the tumor, increase in size, surgery, turns out malignant. Again, this is from Rochester, Minnesota, Mayo Clinic. Tumor, 6 years after gamma knife, turns malignant. This is from Thailand. Vestibular schwannoma, malignant transformation, 6 years after gamma knife. 5.7 years after gamma knife. From Japan. From South Korea, the same, treated with gamma knife, recurred, and 4 years later, excised, and it was malignant. I can go on and on until this is the list of these cases of malignancy following gamma knife. And remember, these are not very long, only 5 and 6 years. Wait until we get cases that had gamma knife 10, 15, 20 years before. So these are the authors and the follow-up. So look at this, 17 years after gamma knife, malignant triton tumor after gamma knife. 17 years, 19 years, 16 years, 13 years, 14 years, even 8 months. So when you wait long after gamma knife, you will see these complications. You will see recurrence of the tumor, and you will see malignant change. These are cases reported in literature. Just putting you all of these cases. Look at this one, 25 years. So much so, people realize that this is a real danger, that in a center like Pittsburgh, they say all patients who undergo radiotherapy or radiosurgery are told of the risks of developing a second tumor. It is a risk, it is there. We're just seeing the tip of the iceberg. One case of mine, a young patient, 17-year-old, who had gamma knife to the lesion here. She came back with another tumor on top that was malignant. So when we excised it, it it was malignant. So the risk of radiosurgery-induced tumors may be higher than previously reported. The overall incidence of radiosurgery-induced tumor may be as high as 11.4%, as high as 11.4%. The risk of radiation-induced neoplasia after surgery may not be markedly different than that following radiotherapy. It is a serious risk that we have to consider. Look at this. With the number of reported cases of radiation-induced tumor is already increasing, we expect to see further major increase in the future because we will see cases that has been treated with gamma knife for many years. This is not a bump in the road. This is only the tip of the iceberg. So if you give gamma knife and fails, then you have to do surgery again. Surgery here is difficult. Failure of radiosurgery renders surgery more difficult, particularly with facial nerve preservation. Very difficult. And these are the papers that say so. Somebody like Majid Sami, 2012, surgical treatment of patients with vestibular schwannoma after failed radiosurgery. What does he say about them? Surgery after previous radiosurgery is the most challenging and is related to the very worst outcome in all surgeries after radiosurgery. So what more evidence do you need? Again, the same principle is said again in the paper published 2016 in the World of Neurosurgery. Functional outcome of salvage surgery for vestibular schwannomas after failed gamma radiosurgery. So people wake up to this fact. I'm challenging you to stop using gamma knife in this very indiscriminate way just because the surgeon does not know how to do surgery because he's a mediocre or he's a novice. So in our Majid Sami says, in our series, all surgeries after failed radiosurgery were more difficult. Why is it more difficult? Because you cannot see normal structures. There's no plane of cleavage. The nerves are very sensitive to surgical maneuver and blood vessels are fragile. So when you operate on a case of vestibular schwannoma who had radiosurgery, it's really hell. This is one case of mine. 63-year-old man from Syria who had gamma knife, and it sort of increased in size, causing severe brainstem compression and almost coma. We had to take him to surgery and operate him. I will show you the video to show how difficult the surgery is. Just here, small still pictures. You can see the colors. You cannot see normal colors. You don't see color of arachnoid or color of cerebellum or color of the tumor. Eventually, we removed the tumor on the expense of facial nerve damage just to salvage his life. Okay, let's see the video. I'll just go through it quickly so that just to show you that the dissection is really difficult. Here, the debulking tumor from inside, you can see the color. This is not the normal color of vestibular schwannoma. There was hyalinized tissues there. Here is the checking the from the tent. Here I'm drilling the internal meatus. Taking the dura of the internal meatus to drill. So this is the internal meatus as seen through retrosigmoid. This is the posterior lip, and this is the superior lip. This is the way we drill posterior lip and superior lip of the internal meatus. I'm just trying to find any normal structure that I can really hear the adhesions of the lower cranial nerve, glossopharyngeal vagus, and accessory to the lower pole here, trying to find the plane of cleavage, and it's really hellish. You don't see well. Adherent, rigid. Look at this. Look at this edema because of radiation. So I will stop here. I think I made my point that surgery of these cases. Look at here. You don't see planar cleavage. Edematous, hyalinized tissues. You don't know what you are dealing with. Okay. This is the pathology of this patient, done by our friend Dr. Hussam Al-Farsakh of the American Board of Histopathology, in Amman, and he diagnosed acoustic neuroma with secondary radiation changes of fibrosis and necrosis. Areas of necrosis here with fibrinous material secondary to radiation. Areas of fibrosis secondary to radiation. Ionized blood vessels due to radiation. Intersecting bundle with many hyperchromatic cells with radiation changes. It is really hell to operate on such cases. So think once, think 10 times, think 100 times before you refer patient to gamma knife or any kind of radiation. There are other methods that can be done, not because it suits you, it must be suiting the patient. My series with these giant ones, all in all, my experience with the acoustic neuroma between 1990 to 2018, 664 cases, less than 4 centimeter majority, more than 4 centimeter 72. So 4 centimeter, more than 4 centimeter 72. I've lost 1 patient, had morbidity in 7. Facial nerve preservation could only be done in 10. And even when you preserve it, there is still some weakness. I use the sitting position using the cranial nerve monitoring and navigation and everything under the sun to give the patient the best chance. 1 patient of mine coming from West Bank of Jordan, from Palestine. This is a grade 5. As you can see, it's crossing the midline, distorting the fourth ventricle. And these are the examples of these patients. So this is my series, some of the cases I've done, very large cases. Some of the cases they had surgery before at other places. They referred for radiation, but of course we did surgery for them. Some of the cases, this 42-year-old female patient with this tumor and the postoperative, the one which I mentioned coming from Palestine with this lesion and postoperative, this large lesion here with some preservation of the facial nerve. 59-year-old female patient with giant one and postoperative. 23-year-old female with this lesion and postoperative. 37 female. This one we had to leave part of the tumor here because it was adherent to the actually this patient had surgery somewhere else. Same here, patient had surgery somewhere else, and he was referred for gamma knife for surgery. Same thing here, before and after. Same thing here. So we managed, but facial nerve function was not being able to be served. In this one, we have good, or somewhat of the facial nerve function is still there. This patient who had this tumor, somebody went in and just took a biopsy from there and followed that by gamma knife, which is the policy that people are adopting. They are after money. They want to do surgery, take the money of the surgery, which is not a good surgery, it's just biopsy, as you can see, and then take the money for the radiation. And to me, this is a crime. To do this to this young patient, 29-year-old, beautiful lady from Iraq, this is a crime. So we took her and we removed the tumor with another good function of the facial nerve. This is the last patient, this 50-year-old male patient from Jordan, giant tumor invading the petrous bone. You can see the amount of invasiveness. The amount of destruction of the petrous bone. The steps that we use to take the tumor out, you can see the temporal petrous is really destroyed. And this is the postoperative picture with the total resection of the tumor and preservation of the facial nerve. This is where the tumor was, inside the petrous bone. Okay, let's see his video. We are at the end of the lecture. I just have short videos to show you, and then we'll be finished. So this is the one with the invasive petrous bone that we have seen. And this is the arachnoid here, this is the tent, and this is the petrous bone bulging out. So I'm gonna go through that quickly. This is here the facial nerve. I went underneath here, taking the arachnoid from the tent, the vein of Dandy, the trigeminal nerve. Coming to this part of the tumor here, the section. Because it is a virgin case, you can see a plane of the cleavage. You can see arachnoid. Here we are opening the cistern between the medulla and the cerebellum, the lateral cistern, to drain CSF out to make the brain lax. You can start seeing the lower cranial nerves and preserve them. And then excise the tumor out with the preservation of the facial nerve completely. These are the lower cranial nerves. This is the facial, and this is where the tumor was. Okay. Again, here the same principle. We open the cistern to drain CSF so that you will not do a lot of retraction on the cerebellum, and then debulk from inside. Debulk, dissect, debulk, dissect. Here, I'm finding the facial nerve towards the meatus. Here, taking the arachnoid towards the brainstem, a good plane of the cleavage. Here, I'm preparing to drill the internal meatus, so I open the superior lip and the posterior lip of the meatus. Rotan dissector to take the dura of the bone. Opening the dural sleeve of the internal canal, and then the drilling of the internal meatus. Then you have seen the nerve here, you've seen here, and then taking the tumor. This is the nerve here. Very careful dissection. So this is the nerve, this is the tumor inside the canal. So you see the nerve towards the brainstem, you see it towards the canal, and you remove the tumor. This is the trigeminal nerve, Meckel's cave, and this is the facial nerve, and this is the cavity, this is the pons. Okay. Last video. Here we are on the right side. Principle is the same. Debulk the tumor from inside, and then open the internal canal by drilling. And here's the tumor. Good plane of cleavage, good colors, good structures that you see. If this patient had radiosurgery, you will see none of this. So peeling the arachnoid towards the important structure, away from the tumor, towards the brainstem. And here you can see the nerve, and then you can take the tumor completely. So this is the facial and vestibular cochlear bundle, freed at the brainstem. Now we want to see them towards the canal. This is to see and gauge the depth of the canal, which is usually 5 millimeter to 18 millimeter in length. So here you can see that the nerves are preserved and the whole brainstem is preserved. Okay. With this, I finish, and I thank you for joining us.
Okay, Dr. Surveyor, thank you very much. Excellent presentation, and we'll open it up right away to the panelists. Okay, the floor is open to say hi to Dr. Surveyor or ask a question related to his presentation. We're slow on the mark. Let's go, everybody. Wake up.
Hi, I'm Sami Khatib from Jordan.
Welcome.
First of all, thank you, Prof. Ibrahim, for the excellent presentation. And what I would like to state again, what you said regarding the fractionated radiosurgery, which will see more and more malignant tumors. Using the fractionated radiosurgery, as you know, it's mainly contraindicated because we are using the radiation for sizes of tumor much more than it's stated when they invented the gamma knife. The difficulty is using this type of fractionated is the overlapping of the fields. So we are giving much more dose of radiation for the same patients because they couldn't precise exactly the previous field when they are going to do the next one. Thank you.
Thank you, Sami. And I have to refer to you and mention too that Sami is a radiation oncologist. And to hear him say that is something really to be respected. There is difference between the radiation diffractionation in radiotherapy, conventional radiotherapy, and the so-called fractionation of radiosurgery. I think what is, it's really crazy to use the term fractionated radiosurgery in large volumes of the tumors, really causing major consequences, major complications, and surely there will be return of recurrence of the tumor and malignancy. So thank you, Sami, for being honest about it. Thank you very much indeed.
Thank you.
Okay, more comments, questions? Okay. Come on now, step forward. I'm not a neurosurgeon, so I can't ask pointed questions. Oh, Dr. Sabea.
Yes.
Hello?
Wow, they're very quiet today. Okay, go ahead. Go ahead.
Yes, that was a very good presentation. I really learned a lot. Thank you very much.
Thank you.
I would like, from your series of so many patients, I would like to find out how many are presented with a sudden hearing loss and how you went about the management of sudden hearing loss with regards the vestibular schwannoma.
Thank you for the question. Very few cases of sudden hearing loss. Usually the hearing loss is really gradual. But I said maybe 3 or 4 cases of sudden loss. So majority of cases were gradual loss of hearing. And the algorithm of the treatment is the same. The clinical examination, the history, the radiology finding, is there brainstem compression, what the grade of classification of this vestibular schwannoma is. So hearing loss is a major complaint, and it should be taken seriously. Denotes that the tumor is really of some size, but sometimes you'll find a small intracanalicular schwannoma with loss of hearing. So you have to take it across the board. and deal with it with the routine algorithm of doing this. Wait and see is one of the options if you have intracanalicular schwannoma with minimal presentation.
Okay, there's a lot of compliments. One person, Z6, asked, any complication related to sitting position?
Sitting position is my favorite. I've been using it for decades. I was trained on the sitting position in St. George's Hospital at Atkinson Memorial in London. My bosses were using that, and I continued using it. I'm very happy with it. My anesthetists are happy with it. I would tell you this: if you master the sitting position, you will not change to another position. So easy, so anatomically orientated. Fluid and CSF just flow down. There's no accumulation of blood inside. Preservation of the anatomical vision that you have. It's really magnificent. The only complication that everybody is dreading is the air embolism. And I tell you this, air embolism is part of any surgery, supine, prone, legs up, legs down, sitting position. It's more in the sitting position, and the management is the same. PCO2 management, pressure management, and introduce it into the esophagus, this, that, and the other, then you can diagnose it and treat it there and then. I say this, there's not a single case of sitting position, and I have done thousands, more than thousands, of these cases without air embolism. Every case of sitting position, there must be air embolism. The anesthetist would diagnose it, treat it there and then, and we would continue. I have to mention this. I've lost one patient, a child, early in my career. I've just finished my study in London and came back to Jordan. And my first case of sitting position was a child I've lost for air embolism. That was the only case I've lost for air embolism.
Okay, very good. There's a question from Dina Dabaneth. She says, thank you for your talk. Is there a role for medical treatment prior to surgery? Have you used bevacizumab as medical therapy for rapidly growing vestibular schwannomas?
No, it has been used and it's proved to be not effective, so I don't use it. As for the medical treatment of vestibular schwannomas, if you have you can use the steroids, the dexamethasone or any type of steroids to decrease the edema, there is hydrocephalus and so on, mannitol as such. I've never put a shunt for vestibular schwannoma. Even if it is emergency, 3 o'clock in the morning with hydrocephalus, I put an external drain and I continue with taking the tumor out. A good shunt is no shunt. Can you remember this, please? A good shunt is no shunt. Don't put shunts into the heads of people. You would not love to put shunts in the head of your son or daughter. So don't put it in the heads of others simply because you cannot do the surgery. The excuse that this was an emergency, life-saving, don't put a shunt. Put external drain and proceed with the final management of the patient.
Thank you for your comment. I think my speakers were not working. So thank
Okay, you're fine, Dina. You're fine.
Thank you.
Dina is from the States. She's a neurologist specializing in MS, and she is a daughter of one of our prominent neurosurgeons here in Amman. So thank you, Dina, for joining us.
Thanks for your lecture.
Yeah, thanks for coming, Dina.
Yeah.
Okay, more comments, please? And if anybody has a question, they can ask it in the chat. Go ahead.
Yeah, thanks a lot, Professor Ibrahim Sevilla. And I'm a regular student of you. Once again, a wonderful talk. You have responded one question which I was thinking to ask about the shunt. And I have seen here practice some neurosurgeon prefer to place a safety burr hole. If patient develops hydrocephalus, so they will immediately put EVD. Is that good, such practice?
Yes, it is part of my surgery. When I finish my surgery, I put a right or left posteroparietal burr hole. I open the dura, and I leave that for emergency. Just in case the patient develops hematoma or acute hydrocephalus, then you can do it by bedside, introduce a ventricular catheter, and solve the problem. So yes, and I also use it when I still in surgery and the patient is still in sitting position, I use this, I put some water into the subarachnoid space so that any air accumulating in the sitting position would come out. So you don't get pneumocephalus in these cases. So two benefits, evacuate the air, and the second one, it's an emergency place for you whenever you need to go through.
Okay, Z6
Thanks for
asked.
this.
Sorry, go ahead.
Okay, continue, Dr. John. Continue.
Well, go ahead, Adam. You have something else to say? You have another?
Yeah,
ahead.
I was asking.
Go ahead.
I was interested to ask about the improvement in cranial nerve functions if there is a, pre-op deficit. Is we can see any improvement in serviceable hearing or in facial nerve function after removal of that tumor?
Yeah, of course.
How much
And I
grades
would,
it?
yeah, I would refer you, of course, it's variable from one author to the other, but I would refer you to the papers published by Majid Sam. He is the single most experienced person on earth in these vestibular schwannomas. And he would tell you how he would preserve the facial nerve, even in large schwannomas. How would he preserve the hearing? I have a few cases where I could preserve the hearing. So there is a benefit of doing surgery. But look again and compare this with the gamma knife or with radiation. You know, the teaching and the classical teaching, you give the gamma knife today, you will get the result in 2 years. The first result appears in 6 months' time. How would you wait with such pressure on the cranial nerves and the brainstem? How would you think of what were your ideas of doing this? So yes, cranial nerve improvement, brainstem function improvement, pyramidal weakness improvement is there.
One more question about I was reading a paper from Dr. Majid Sami about the use of combined approach, endoscopic, microscopic assisted. Do you prefer in the management of vestibular schwannoma?
Yes.
Any
This
role of
is called endoscopy assisting craniotomy. So when you finish the surgery and you have some blind spots, you can put the endoscope to see the blind spots. But surgery is the mainstay. So it is surgery assisted by endoscopy at the end of the surgery to see that you have done a good job.
It can give any benefit in complication avoidance related to nerve function preservation,
it's good in just seeing a residual tumor that you could not see. Professor Sami would do suprameatal drilling so that he would flatten the area when you reach to the trigeminal cave so that you can see. Sometimes you don't see through surgery because of the acute angle. So putting an endoscope will tell you whether you have left a tumor there, but it has nothing to do with avoidance of complications.
Thanks a lot, sir. Thanks.
Okay, doctor, you have another question from Z6. In your practice of giant vestibular schwannomas with hydrocephalus, how many patients still required a shunt later?
Yes, hydrocephalus and schwannomas, you would find hydrocephalus in cases of vestibular schwannoma, even there is no compression of the fourth ventricle. It is said that schwannomas produce high proteinaceous material or some endogenous material that would cause increased protein in the CSF and therefore block the CSF pathways in the subarachnoid space in the skull base. So how many cases are caused, hydrocephalus is caused by the tumor, and how many cases the hydrocephalus is caused by this protein is variable. In my series, I have seen both, and I try not to put a shunt unless it is really necessary. How many cases do I need to put a shunt? Out of all these 600 cases or something, I need to put a shunt in only 4. So I believe a shunt is good, but don't use it indiscriminately simply because you cannot do the surgery.
Thank you. Okay, more comments, questions? Okay, here's another question. Gerald Musa asks, what is your opinion on the use of intraoperative facial nerve monitoring?
It's very important. I would not do surgery without it. I have to have it. And if it is not there, I would just postpone the surgery. It is very useful. You need to see the beep of the facial nerve signal. You don't want to lose it. It's there. Of course, your anatomy, your navigation is yourself. You know where to find the nerve and how to find the nerve, how to find the fibers through this arachnoid layers. but monitoring of the facial nerve function is mandatory.
Very good. Let's see. Go
Sir,
ahead. Go
once
ahead.
again,
Adam.
sorry.
Go ahead.
One more question. After surgery, section of the tumor, what about the closure? We see a lot of cases with the CSF leak, but you prefer any dural graft or artificial dura or sealant, some sealants. What do you prefer to use, sir?
I always use the dura, always. Even if the dural flap would close easily, I would like to have it baggy because of any complication that would arise, the dura would be baggy. So I always use a dural graft to close the dura. And I prefer the fascia from the patient himself, from the fascia lata, from the thigh, or from other sides. If not, if the patient doesn't want another incision, another scar, then I would go for artificial dura. And I use this cadaveric type of artificial dura. Suturable ones.
And you put over sealants above that, fibrin glue or?
If the closure is good, I'm happy. If I feel that, well, some area needs to be fortified, I put some dural sealant.
Thanks a lot, sir.
Okay, more comments, questions from the panelists? Now's your chance.
Good evening, sir. I'm Rajesh, a resident of neurosurgery from India, sir.
Welcome.
Sir, what is your opinion regarding decompressive craniectomy or craniotomy, sir, in retrosigmoid approach? And will we reposition the bone back, or we'll just do craniectomy, sir?
And depends upon the thickness of the bone. We always say that people differ in the thickness of the bone, whether it is in the frontal area or the posterior fossa. So if the bone is thin, I would like to raise it as a flap and put it back. If not, then I will use a craniectomy. And then I would fill the gap by putting mesh, reconstruct it by putting mesh with the screws.
Okay, sir. Thank you.
Very good. Very good. More questions, comments? Nothing else? Okay. Okay, very good, Dr. Sabaya. Thank you very much.
Thank you.
And you'll be presenting Wednesday again, correct?
Wednesday, yes, the same time, 5 o'clock, and we'll be talking about the radical excision of craniopharyngiomas.
Okay, very good. Okay, let me just use this time to announce another presentation by a panelist from the Congo. Could you say a few words? Ahanga, are you there? I just wanted to
Yes,
talk.
I'm there, sir. Thank you
Yes,
so much.
Yes, go ahead, Ahanga. Tell us about your presentation in a couple of hours from the Congo.
Yeah, thank you so much. We are talking this evening in trauma patient management, and this evening we are going to present about head trauma management and the limb management. So,
okay, and you're a
the presentation will be in French.
Okay.
But sometimes we use English to let those who cannot speak French, who cannot understand French, to catch something from this presentation. And we thank you so much, Dr. John, for your support for this.
Oh, of course. Well, Dr. Sabaya, it's such an ambitious group of people over there in the Congo. Wow, they've really grabbed this platform, and they're like you. They really like it, and this is their second week, so we look forward to doing that. And okay, thanks everybody for coming, and we'll see you Wednesday, Dr. Sabaya.
Thank you very much.
Thank you.
Bye-bye.